show an example of personalized alignment planning with PSI guides using restricted kinematic alignment technique. This is an X-ray of a 71-year-old male with significant valgus deformity. This 10 to 15 degrees fixed flexion deformity. Medial collateral was clinically intact. My preference to use a next-gen CR flex. This has a 9 mm distal thickness and 11.5 mm posterior thickness in the femur. My preference is to do a 10 mm distal cut and 12 mm posterior cut when there is no loss of cartilage. In this plan, the default plan is based on mechanical alignment principles, the neutral, tibial and femoral cuts, and rotation based on epicondylar axis. Subsequently, I will show how I plan for restricted kinematic alignment. So that's how the planning software looks. You can see 7 degrees supine valgus. So the standing valgus will be more. So that will be the neutral mechanical cuts, 0 degree varus valgus, both in the femur and the tibia, rotation based on the epicondylar axis, 7 degree posterior slope. So as per the plan, I'll be cutting 10 millimeter distal medial, femoral condyle 2.5 laterally, proximal tibia 5 millimeter medially and 0.5 millimeter laterally, and the posterior section is 12 millimeter medially and 8.5 millimeter laterally. Now I'll show a video showing salient features of planning.
Let's see what happens when we remove the cuts and put the implants. And you can see now distally there is much more metal on the lateral aspect and overstuffing the distal lateral condyle. Now we know that because we are taking only 2.5, so we can decrease the overstuffing by following the native anatomy. I need to put in more valgus compared to neutral mechanical axis, so that's what I'll do now, putting in more valgus. So now I can look at distally. A little bit metal still there, so I can more valgus. So we're almost there. Now if you look at the valgus side, it's about 9.5 degrees compared to neutral mechanical axis. So obviously that's quite a lot. So the question is, what was the pre-arthritic anatomy? So one of the unique features of this software is that it has something called as cartilage mapping, and we can put the landmarks as well. So red means 0 cartilage, green mean about 3 millimeter cartilage. So now if you look here, so the red on the lateral side suggests there is no cartilage, so we need to add 3 millimeter to whatever measurements the cuts are showing. Medially there's not much wear. We know there is complete cartilage loss on the lateral side and probably minimal bone loss, so we probably could add about 4 millimeter. So now I'm putting in 3.5 degree valgus. So it looks like as if there is a metal, but if you look here, the cut measurement is about 5.5. So if we add another 4, it's almost 9.5. So I think that probably is the pre-arthritic anatomy. So I will accept that. Now posteriorly, based on the epicondylar axis, now you can see I'm taking 12 medially, 8 laterally. That doesn't follow the anatomy. Now I'm going to go to the posterior axis. Now you look here, it's about 12 and 11.5 millimeter cuts, which is almost equal. Now coming to the tibia, this is the mechanical alignment section, 6 medially and 1.5 millimeter laterally. Now we can come to the cartilage mapping. You can see there is minimal wear medially. Laterally we know there is bone loss as well as cartilage loss. With regards to the HKA angle, I didn't want to put him in 3.5 degrees combined valgus, so I want to put a little bit of varus in the tibia. I'm putting 2 degrees of varus. That will give 1.5 degrees of valgus HKA angle. Now we can see that is medially we are taking 8 and laterally 1.5, but we know there is very minimal medial laxity as we can see in the x-rays, so that's probably should be fine. The other thing I could do is see the posterior slope. I will put a 7-degree slope, but in this case we can see it's almost parallel to the native slope of the patient. Okay, this is the final plan. As we can rotate it, we can see essentially we are resurfacing the femur to the native anatomy as much as possible, and the tibia gives some varus to avoid too much valgus.
So that is the intraoperative situation. Usually with mechanical alignment, I would have had to do iliotibial band pike resting and also posterolateral capsule release in these cases. I didn't have to do either of those. That's the stability and the tracking. So that's how it started. That's the planning. That's the post-op X-ray with the CR flex knee. And that's him 4 hours post-surgery. Excellent range of movement. That's him at 3 weeks post-surgery. He's in the video himself. And you can hear the windy North Wales coast. This is him at 6 weeks post-surgery. And he's got excellent range of movement and is extremely happy.